Cytopathology to share with us a talk entitled Challenges in Thyroid Cytopathology. So even though everybody knows who she is, I'll just give you a very brief summary of her 25-page CV. So what I'd like to tell you is that she finished medical school when I was still in diapers in 1978 from University of Alexandria in Egypt. And she obtained her diploma in clinical pathology in 1983 from Royal Postgraduate Medical School in London. And she received a doctorate of medicine from Otago University in New Zealand in 1998. She was probably one of the first FIAC fellows in Malaysia, which she obtained in 2010. And Prof. Sharifah has been one of the longest trainers, teachers in cytopathology in Malaysia. And if I remember correctly, Dr. Mukarramah was one of her earlier students that she supervised. And at the moment, Prof. Sharifah is the esteemed president of the MSOC. And at the moment, she's the lab director of Pantai Premier Pathology, Pantai Hospital, Kuala Lumpur. So yes, that's a brief summary of her 25-page CV. So, okay, Prof. Sharifah, are you ready?
Okay.
Boleh,
Yes.
Prof?
Yeah, boleh.
Okay.
Can you hear me?
Yes, we can hear you.
Okay. Clear?
Reasonably clear, Prof.
All right. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. Good morning. Good morning. I'm very lucky today that two of our colleagues have covered great grounds in cytopathology of the thyroid. Dr. Mukarramah has done a great job by giving the lecture on thyroid cytopathology, which makes my presentation easier. And also Dr. Nur Asmaliza has presented a few difficult cases. So as we go along, we will be covering a lot of grounds in thyroid cytopathology, as well as the pitfalls and how to manage and report thyroid cytopathology in our routine practice. Okay, I'll start with so as we all know, FNA is a long-standing technique used to obtain diagnostic material from patients with thyroid nodules. But of course, situations exist in which diagnostic categorization of the FNA aspirate is not quite straightforward. And these lesions may be benign entities with cytomorphology that mimics malignancy, as well as malignant entities with unusual cytomorphology. And this we meet with these problems every day in our routine practice. And a definitive diagnosis is not always possible. So I think Dr. Mukarramah has given you how to classify and categorize all these lesions. And if we cannot make a definitive diagnosis, that will go into the atypical or undeterminate diagnosis, which is the most appropriate. So I'll just just pick out the lesions that will give problems for us in our routine practice, and highlight all these lesions and try to discuss how to overcome the problems. So benign entities that mimic malignancies most of the time is the hypercellular nodular hyperplasia, which we find a lot of papillary hyperplastic structures in benign papillary hyperplasia. The next one is the Hurtle cell nodule, which has been highlighted by our first two speakers. then Graves' disease with nuclear atypia, Hashimoto's thyroiditis, cystic lesions, and another area is hyalinizing trabecular adenoma, presence of squamous metaplasia in smears, and of course the parathyroid gland, parathyroid tissue adenoma, which has been highlighted by Dr. Noor Asmaliza. We start with cystic lesions. Cystic lesions can be quite difficult or straightforward. Yeah? The pitfalls in evaluation of cystic lesions and hyperplastic nodules very often cause diagnostic difficulty. And cysts in the thyroid are very common. But remember, most of them are benign. And also we have to remember that occasionally we get malignant neoplasms, which may also present as cystic lesions. The cystic lesions of the thyroid may be of may occur in three, maybe due to three categories. First, whether they are true cysts or not. And second one is nodular lesions with cystic degenerations. And the third category are really malignant lesions with cystic degeneration. So the true cysts in the thyroid gland usually comprise of thyroglossal cysts, parathyroid cysts, epidermoid cysts, branchial cysts. Now, depending on the FNA tract, the needle tract, sometimes you get follicular epithelium within the aspirates, which can cause difficulties. If you have pure components like ciliated cells, lymphocytes, squamous, colloid, keratin, it may be quite straightforward. But if you also see follicular epithelial cells, then it might cause some difficulty in interpretation. And of course, when you get a papillary thyroid carcinoma associated with a thyroglossal duct cyst, that would be very challenging. Although it is rare, but we have to always keep in mind some of these rare lesions. The pseudocysts or hyperplastic nodules with cystic degeneration. Hyperplastic nodules tend to undergo cystic degenerative changes, reparative changes, and when you look at the aspirates, you'll see all these features: hemorrhage, stromal fibrosis, hyalinization, cells with which look spindly, follicular cells which have atypical nuclear features, and the aspirate may be may show quite florid atypia. And these cystic lesions in arising from hyperplastic nodules can cause can be a significant cause of false positive and false and negative results in thyroid FNAs. Malignancies is cystic component. We can have follicular neoplasms, as I mentioned just now, with degenerative cystic changes, PTCs, and also medullary thyroid carcinomas may have cystic components, although papillary thyroid carcinomas are more often more associated and not as rare as medullary thyroid carcinoma in our routine practice. Usually, for cystic lesions, the aspirates are usually yield hypocellular specimens, therefore can causing false negative. These are some of the examples, and if you remember, this image has been shown by Dr. Noor Asmaliza. Obviously, we are taking from the same literature review, and I will give you the reference at the end of my talk, and I would recommend very much, as this is a very good paper for all of us to read by Fernando Schmidt. Now there are 4 images here. A is you can see a reactive or reparative epithelial thyroid epithelial cells, and you can see that these cells can have nucleolus, usually normal follicular thyroid epithelial cells don't have nucleolus. I used to tell my students, the moment you see nucleolus in the right background, you have to think of a neoplastic process. And then sometimes this reparative or reactive changes, the cells can also show pseudo inclusions. Yeah? They are not true inclusions, pseudo inclusions. And of course, you can also see grooves, occasional cells showing grooves. This is a reparative or reactive thyroid follicular cells. But of course, you have to look at the background. So important to look at the background. And you can see the clues there. For instance, in this case, you can see the histiocyte inside this group of cells. In this image, these reactive epithelial cells display sort of elongated, oval elongated nuclei with dense cytoplasm, and which can look a bit atypical, yeah, very atypical. Doesn't look like as though they are the normal follicular epithelial cells. And in this image, you can see cells with exaggerated cytoplasmic processes, spindle cells, which looks very atypical. So if you are not thinking of degenerative process and you are not familiar with this, then you may make you may overcall this type of cases. Like in this image, you can see a cluster of cells, cells with hypervacuolization and giving you a histiocytic appearance. This is a papillary thyroid carcinoma with cystic changes. It's a cystic PTC. And this cluster of cells can easily be missed as a cluster of histiocytes. And we can undercall this. An example of cyst lining cells, you can see the cells can be quite spindle, plump, very atypical, and some of them have real looking intranuclear inclusions mimicking papillary thyroid carcinoma. So always look at the background. Hypoplastic nodules, again, Dr. Mukarama has discussed this in detail. Normally, in a smear with hypoplastic nodules, the smears can be very cellular, hypercellular. Hypoplastic nodules usually are composed of follicular cells with small round dark nuclei, and it has a honeycomb arrangement. The follicles could be of variable sizes, and it can also have pseudo-papillary formation. But the background will show watery colloid. Yeah? If there is cystic degenerative changes, you can see abundant watery colloid in the background. And cytoplasm of the cells vary from scanty to multivacuolated, plump, or compositic. And sometimes you can see focal nuclear atypia. Some cells can show groovings. And these cells show very nice chromatin clearing. It can look like papillary thyroid carcinoma. Yeah? So the features can be overlapping, and these lesions can cause diagnostic difficulties. So these are other examples of hypoplastic nodules. You can see sheets of cells, folded sheets of cells with overlapping nuclei, pseudopapillary formations. The chromatin is clear. The cells has small nucleolus, and of course, you may be thinking of a neoplastic lesion. But here you can see a histiocyte, so it's a clue that, okay, this may be a degenerative or a reparative epithelial cells. And you can see in these images the hypercellular aspirates of hypoplastic nodules. forming papillary structures and proliferative follicular epithelium, which may appear neoplastic to the novice. Again, more hyperplastic nodules with papillary-like structures. So always look at the background, look at the nuclear features carefully before you interpret. In hyperplastic nodules, the presence of abundant loose watery colloid can avoid overdiagnosis. But still you have to remember two scenarios, a macrofollicular variant of PTC and a cystic PTC. Always, this has to be in the back of your mind. So a careful search for nuclear detail is very crucial. Cystic PTC. In cystic PTC, the tumor cells show, this is a cluster of tumor cells showing cytoplasmic hypervacuolization. Now, if you look at this image, you can see a cluster of follicular epithelial cells with enlarged nuclei, clear chromatin, showing some grooves, and also intranuclear inclusion. Sorry, it's quite small, but you can see, I think, if you look at from your laptop, you can still appreciate the features here. So this cluster has got some features of PTC, but in the background, you can see scattered histiocytes, and therefore this can be quite a problem in diagnosis. This is an example of cystic PTC. So in some books, they describe as a useful clue. One useful clue is to look at presence of thick, sticky colloid or bubblegum colloid that may be sticking around these clusters of cells that may give you a clue that this could be PTC. I know it's not easy, but we have to look for all these small clues. Okay. The next pitfall in the diagnosis of thyroid cytopathology is Graves' disease. Graves' disease usually have cells, as shown by Dr. Karama in her lecture, oncocytic or non-oncocytic thyroid follicular cells, flame cells. Sometimes they can have also watery colloid in the background. They usually have lymphocytes, and rarely they can have granulomas. But of course, cytologic findings can be challenging, especially after treatment in Graves' disease. So post-treatment of Graves' disease, the cells may show pleomorphism, hypochromatism, elongation of nuclei with grooves, and sometimes you can even see inclusions. And sometimes you can also see papillary structures showing nuclear features suspicious of PTC. So this is quite difficult diagnosis interpretation unless you know the history. So it's very important to have the clinical history. This is an example, Graves' disease. You have a cluster of cells here with some nuclear anisocytosis and atypia, which may be mistaken for atypia in PTC. So and in this case, you can see hyperplastic nodules arising in the setting of Graves' disease. Very challenging. So therefore, clinical history is very important. If you see these flame cells, then it's okay. You can see these are flame cells. So you can see the flame cell, you know that the patient is probably the Graves setting of Graves' disease. So you have to be careful when you see the atypical features, not to overcall. And this is an example of therapy effects, post-radioiodine therapy. You can see the cytological atypia seen in some of the cells. The smears can be hypercellular with microfollicular pattern seen, prominent atypias, bizarre cells mimicking malignancy. Next is in lymphocytic thyroiditis. Now, lymphocytic thyroiditis on its own is a well-established entity with very typical clinical and cytomorphological findings. Usually, smear shows a mixed population of polymorphous population of lymphoid cells with tingible body macrophages, some clusters of oncocytic cells, which is very classical of lymphocytic or Hashimoto's thyroiditis. But occasionally you can you can be faced with problems because Hashimoto's thyroiditis, the aspirates, it depends on the stage of the thyroiditis. In the cellular stage, you see a proliferation of oncocytes. Sometimes these oncocytic cells can also show nuclear atypia, cells with prominent nucleolus, and sometimes they even have grooves, and sometimes they will even have inclusions. So one has to be very careful. Look at the background, see whether there are some lymphocytes. So if you see lymphocytes, you have to think of thyroiditis. And this is a common cause of false positive papillary thyroid carcinoma diagnosis. And here you can see also a Hashimoto's thyroiditis with cells showing pseudo-inclusions. In the fibrotic stage of Hashimoto's thyroiditis, you can get squamous metaplasia, and which may also mislead us to be suspicious because of the atypical cells, maybe spindle cells, which we may think that it is suspicious of malignancy. However, malignancy, PTC, can arise in Hashimoto's thyroiditis. Arising in Hashimoto's thyroiditis is not rare, and it should not be downgraded as atypia or suspicious. The other one is the Watins variant of PTC, which should also be excluded in an aspirate composed of oncocytic cells and lymphocytes. You can see the cells here with showing pale chromatin with nuclear grooves and inclusions. So these are challenging situations that can cause pitfalls in the interpretation of thyroid cytopathology. Sometimes you get a dominant nodule in Hashimoto's thyroiditis, which may produce aspirates mainly composed of oncocytes present with macrofollicles, microfollicles, trabecular or solid sheets that could be interpreted as oncocytic follicular neoplasm. So this could lead to an unnecessary lobectomy. So always look for background clues that avoid us from over-diagnosing these conditions. Example of this dominant nodule in Hashimoto's thyroiditis. Here you can see clusters of thyroid epithelial cells arranged in microfollicular pattern. So the first thing is a follicular. I have to exclude the follicular neoplasm. But if you look carefully, you can see these vague microfollicular structures. But if you look carefully, you can see a plasma cell here. So, and look at the background, maybe you can find some lymphocytes. So be very careful. This is not a neoplastic. And don't overcall this is Hashimoto's thyroiditis with oncocytic change. Sometimes you can see Hashimoto's thyroiditis with a lot of lymphoid cells, monoclonal lymphoid population, and this can pose also a lot of difficulty because lymphomas can arise. You know that lymphomas can arise in Hashimoto's thyroiditis. So aspirates in florid with a florid lymphoid phase can be another pitfall in interpretation, and this may be confused as low-grade lymphoma. So if you have extra pulses, always I usually tell my staff to get extra pulses and keep the fluid. You may need it for flow cytometry analysis, you never know, but it's very useful. Follicular lesions of the thyroid basically encompasses adenomatous nodule, follicular adenoma, follicular carcinoma. And you know that this falls into the follicular neoplasm or suspicious for follicular neoplasm category. And other lesions that can be considered under this category would include the difficult follicular variant of PTC, the polydifferentiated carcinoma, the parathyroid adenoma, and other entities. So if we have difficulty in trying to identify or interpret, we see microfollicular patterns, this can be considered under this category, suspicious for follicular. Some examples, this image is an adenomatous nodule, meaning that it is a follicular hyperplastic nodule, and B is a follicular carcinoma. It also has microfollicular structures, and C is a follicular variant of PTC, and D is a parathyroid adenoma with prominent vascular network. So what they have in common is that they are cellular, they have got microfollicular structures, all appear the same, but there are very subtle differences. So you have to look for these clues. For adenomatous nodule, you have to look at the background and exclude and look for presence of colloid, thin watery colloid, and other degenerative features. Follicular carcinoma, of course, you cannot make a diagnosis on cytology, but these lesions, you have to say, is follicular neoplasm. And parathyroid adenoma, you can see they are usually composed of small microfollicular structures, and the nucleus is usually small and round. The ones that you see presented by Dr. Noor Asmaliza, which is a parathyroid carcinoma, the cells are more pleomorphic, and it has got a lot of this one, yeah, it has got a lot of some pleomorphic nuclei as well, but this one is a follicular variant of PTC. It's not easy because, as I think Dr. Mukarama mentioned, that in follicular variant PTC, the nucleus don't usually show intranuclear inclusions. It's very difficult to find intranuclear inclusions in FVPTC. So these are the lesions that would be thrown into the follicular neoplasm category or suspicious for follicular neoplasm. Here, this is a higher view of parathyroid adenoma. You can see the cells are arranged in microfollicles. The nucleus are very uniform, small, round, smooth nuclei. And if you look at the nucleus compared to normal thyroid follicular cells, it gives you an impression. First impression is they are slightly small compared to the usual thyroid follicular cells. That would sort of twitch or tickle your thoughts. What am I dealing with? Should I exclude a parathyroid lesion? Okay. This is the dyshomogenetic goiter. You can see also microfollicles, vague microfollicles, but there's no colloid. And then this is a VPTC. also vague nuclear microfollicular structures. But if you look at the nucleus, it is more slightly larger with fine chromatin, open chromatin. Some of the cells have nuclear groups, but it's difficult to see the intranuclear inclusions. Yeah? And this is a polydifferentiated thyroid carcinoma. You can see some kind of vague microfollicular formations. Okay, what they all share is that they have microfollicular arrangement, but they have very scanty colloid in the background. So if you see this, you have to maybe start thinking of follicular neoplasm. So when an aspirate is predominantly composed of microfollicles, background and accompanying components should be carefully analyzed. The presence of lymphocytes, histiocytes, abundant colloid, cystic changes, stromal fragments, honeycomb arrangement mostly suggest a benign lesion. Okay? And uniform proliferation of microfollicles with very scanty colloid indicate neoplasms. And cellular aspirates with scanty colloid composed of microfollicles in more than 50 to 70% are evaluated as follicular neoplasm or suspicious for follicular neoplasm. Whereas cases with colloid in the background showing micro and macro follicular pattern are not covered by this term, even if the aspirate is hypercellular. So sampling from microfollicular or cellular areas of benign nodules may trigger a diagnosis of follicular neoplasm or suspicious for follicular neoplasm and may give rise to unnecessary surgery. As we all know, the cytomorphology could not allow us to distinguish between follicular adenoma from follicular carcinoma. And the biggest threat in follicular lesions in thyroid cytopathology is the follicular variant PTC, which have to be excluded from this follicular neoplasm or suspicious for follicular neoplasm category. And intrathyroidal parathyroid adenoma is another entity which you have to remember that can present with follicular pattern and microfollicular pattern, but with lack of colloid. Okay, another entity which we have, which can give a big problem to us and we can overcall is hyalinizing trabecular adenoma. Now, these lesions are often very cellular on FNA. And cells can look very atypical with nuclear features that looks exactly like PTC. The neoplastic cells are enlarged, elongated, with overlapping nuclei. Numerous pseudo-inclusions, intranuclear pseudo-inclusions are seen. Until when you see these lesions, you may wonder, if it is a PTC, you don't really usually see a lot of intranuclear inclusions. In these lesions, there are a lot of intranuclear inclusion. You don't need it's not hard to look for it all over the place. So cytomorphological features overlap with PTC and sometimes with medullary thyroid carcinoma because MTC cells also have intranuclear inclusions. So these lesions are at risk of being diagnosed as malignancy on FNA, but these lesions are actually benign. So be careful. And sometimes there is a variant of hyalinizing trabecular adenoma where the cells can mimic an adenoid cystic carcinoma on smears. It's very rare, but it's good to know. The presence of small cells surrounding spherical bodies like that can mimic an adenoid cystic carcinoma, and we can, before we get excited and call this adenoid cystic carcinoma, we have to look carefully at the other cell classes and also the individual cytomorphology. Oncocytic lesions covers a spectrum from hyperplasia, metaplasia to neoplasia. And oncocytic cells, just like in follicular neoplasm or follicular lesions, oncocytic cells basically have abundant fine, granular, dense, eosinophilic cytoplasm, and you have a round nuclei centrally placed with prominent nucleoli. Oncocytes and hyper-functioning thyroid follicular epithelial cells may look similar, so we have to be careful. The only fine difference is that oncocytes have well-defined cell borders and granular cytoplasm, okay, whereas hyperfunctioning thyroid follicular epithelial cells do not. So we have to really look carefully at the cytology. This is an example of a hypoplastic nodule with oncocytic hyperplasia, and this is a follicular adenoma oncocytic type. Okay. So you can see the difference. The cells here also have abundant cytoplasm, and in this, these oncocytic cells have got abundant cytoplasm. But the feature here, the difference is that it has very, oncocytes have prominent nuclear borders and centrally placed, yeah, with granular cytoplasm. And if you look, which is the difference between the hypoplastic nodules, the hypoplastic oncocytic cells or the metaplastic oncocytic cells do not show these prominent features as in follicular adenoma oncocytic type. So pitfalls in the diagnosis of oncocytic lesions are quite similar to follicular lesions, and they may be analyzed in three parts. Differentiation between non-neoplastic and neoplastic lesions, true oncocytic neoplasia versus oncocytic variants of other thyroid malignancies, and of course oncocytic adenoma versus carcinoma, which is impossible by cytology. This image here shows a PTC with oncocytic features. You can see the cells show oval nuclei, pale chromatin, nuclear groups, and maybe elsewhere you can find inclusions. But in this image, you can see only these features. And in this image, you can see a medullary thyroid carcinoma with large granular cytoplasm, but with eccentrically placed nuclei, mimicking oncocytic cells. So these are the mimics of the cytological mimics, which we may accidentally mistaken it for an oncocytic lesion, which is actually not. Now, there is a paper by Elliott and colleagues who studied from 14 cytomorphological features. The following are endorsed as malignancy. As the following features are endorsed malignancy for oncocytic aspirates. Of course, it is not 100%, but these are features that you can think of that can have a possibility of towards malignancy. Presence of non-macrofollicular architecture, absence of colloid and inflammation, and presence of blood vessels, transgressing blood vessels. So aspirates from oncocytic neoplasms are usually composed of more than 70%. So the percentage of oncocytic cells is important to assess an oncocytic lesion. The next one is PTC. Now, papillary thyroid carcinoma is the most common thyroid malignancy. It is important for us also to try to differentiate the aggressive variants from non-aggressive variants, if possible. PTC is one of the tumors that have many variants, yeah? And it's not easy to differentiate between the other variants. One of them is, of course, a follicular variant PTC, which is very difficult to differentiate from other follicular lesions of the thyroid. cytological diagnosis of PTC is based on pattern and nuclear features that we all know and are familiar with. Nuclear features, nuclear enlargement, oval shape, irregularity of the membrane, chromatin clearing, grooves, inclusions, nuclear overlapping. These are the, among these, the most specific is the presence of intranuclear inclusions. Now, nuclear grooves should be widespread and clear rather than focal. So if you see in an aspirate, presence cells with nuclear grooves, but it's just focal, you have to be careful. For PTC, you have to see more than just a focal change in the focal presence of nuclear grooves. It should be more widespread. And a uniformly enlarged or oval nuclei is also important in the diagnosis. Okay. You can see here PTC, crowded sheet of cells with nuclear overlap, presence of inclusions. And a higher view can appreciate the beautiful grooves, the chromatin clearing, and the crowded, which is typical of PTC. Now, patterns of cytologic atypia mimicking PTC, you can have also pseudopapillary formation, presence of intranuclear inclusions in parathyroid adenoma. So be careful, as I mentioned earlier and shown by Dr. Noor Asmaliza, presence of in parathyroid adenoma, you can see papillary structures too. Sometimes dystrophic calcifications and dense colloid bodies may be misinterpreted as samoma bodies. And also some degenerative fragments can mimic bubblegum colloids. So we have to look at the features very carefully. So all cytology features cannot be present. You remember that sometimes all the cytology features cannot be present in each case, each and every case. So one have to be very careful not to miss. Having said that, you have to be very careful not to miss a PTC. On the other hand, and you should also not overdiagnose atypia in benign entities as PTC. Okay. So any findings which is equivocal, you can put under atypia of undetermined significance and suspicious of malignancy. I mentioned earlier that PTC has many variants. We have tall cell variant, columnar cell variant, diffuse sclerosing variant, hobnail, solid variant, widely invasive follicular variant, and these are accepted as aggressive variants of PTC. So if we can recognize this, they should be mentioned in the report. Example of a tall cell variant, you can see cells with abundant columnar shaped cells with abundant cytoplasm, and also columnar cell variant, which I may say that it's very difficult to identify and to interpret on any of the thyroid. Medullary thyroid carcinoma is much more aggressive, is a much more aggressive tumor. It could be misdiagnosed as an oncocytic follicular neoplasm or a papillary thyroid carcinoma. This tumor is characterized by many single cells and loose tissue fragments. And sometimes you can also see follicular formations in the smears. Papillary structures are very rare, but occasionally it can be present and therefore give us problems in interpretation. And if microfollicular structures are present, it may also mimic a follicular neoplasm. And that is again a recognized pitfall in interpretation of MTC. True oncocytes display central nuclei with macronucleoli, which is unusual for MTC. So sometimes you can, oncocytes can be, because the cells in MTC has got abundant cytoplasm, we may think that they are oncocytic cells. The oncocytic variant of MTC is very difficult to differentiate from an oncocytic neoplasm. So MTC can also mimic PTC in the presence of amyloid. In this case, because of the amyloid can resemble thick colloid, and because MTC also have intranuclear inclusions, so it could be mistaken for PTC. And sometimes the smears could have only dispersed cells, singly dispersed cells, which could be mistaken or misinterpreted as lymphoma or plasmacytoma because of their plasmacytoid features. And if the spindle cells predominate, it can be confused with mesenchymal tumors or regenerative processes, or even anaplastic carcinoma. Presence of pleomorphic tumor giant cells in the giant cell variant of MTC may mimic anaplastic carcinoma. So this is also, these are the problems that you may, although it is rare, but you have to remember all these possibilities. And if you think of MTC, you're thinking of MTC, it is better to do immunohistochemical studies to confirm MTC. This is an example of the dispersed cell patterns, plasmacytoid appearance, and spindle morphology. And the tumor cells usually have an intranuclear pseudo inclusion. And sometimes you can see large cells which may be mistaken as anaplastic, maybe carcinoma. And presence of small clusters of cells can also be mistaken. Sometimes you have metastatic tumors in the thyroid. Example, metastatic pulmonary carcinoid tumor, which can mimic a medullary thyroid carcinoma. So clinical history is also very important, and radiological correlations. Rare tumors of the thyroid would include schwannomas, angiosarcoma, solitary fibrous tumor, granular cell tumors, paragangliomas. They are indeed very rare, and maybe maybe some of us will be presenting later. These lesions are definitely challenging due to their rarity and lack of prior history, and probably immunohistochemistry may be helpful in most of the cases. Otherwise, we can lump it under atypia of undetermined significance. Example of some metastatic lesions: metastatic renal cell carcinoma, metastatic melanoma, which I've seen in these two cases in the 40 years of practice in thyroid cytopathology. I think this is the last slide. Poorly differentiated thyroid carcinoma arising from thyroid follicular cells. This carcinoma arise from thyroid follicular cells. They are very difficult to interpret on thyroid cytology on smears because they don't have distinctive features of well-differentiated thyroid CA or PTC. It's very difficult to diagnose this on cytology. The classic form is the insular carcinoma. The diagnosis can only be definitively made on resection. This is an example of poorly differentiated thyroid carcinoma. You can see that the cells are monotonous, no differentiating features. Maybe sometimes you can see some palisading at the edges. No features of PTC. Background is clean, hemorrhagic, but clean. No colloid in the background. So I just would like to summarize my lecture, and this is together with some experiences that I've had with thyroid aspirations. You must remember that most thyroid lesions are benign. Most of these colloid Most of these are colloid nodules, and most colloid nodules can be diagnosed by cytology. In other words, most thyroid FNAs can be diagnosed on cytology. Most malignant nodules are PTCs, papillary thyroid carcinomas, and most PTCs can be diagnosed on cytology. Most thyroid cancers, poorly differentiated, anaplastic, MTC, can also be diagnosed on cytology. Okay. Maybe poorly differentiated is, I maybe remove this, but anaplastic, medullary CA can also be diagnosed by cytology. And most other non-neoplastic conditions, example, most cases of Hashimoto's thyroiditis can also be diagnosed on cytology. So most diagnostic problems relate to highly cellular follicular lesions. And most cellular follicular lesions, by far, remember, are benign. Follicular carcinomas cannot be diagnosed or excluded with certainty by cytology. We all know that. And another diagnostic gray zone is the Hurter cell nodules. You can't diagnose them either. And other important facts to remember is the presence of colloid is not an absolute requirement for the diagnosis of nodular goiter. Okay? And the absence of colloid is not an absolute criteria for diagnosis of a neoplasm. The differentiation of nodular goiter with atypical cytologic features from various other neoplastic entities is best understood when one is familiar with the cytopathology features of thyroid neoplasm. So the more you see, the better you get. Okay, so this lecture is taken from these two papers. You can look up these two papers by Fernando Schmidt and by, you all know, Said Ali. So I would recommend you to read this. Thank you very much. That's all.